welcome everyone. I hope you can all hear me okay. And I think I'll mention right off the top, maybe keep your microphones muted until we get to the point of, where we get into questions and whatnot, just to avoid any ambient background noise. So welcome. Appreciate you joining us today for what is the 5th lecture in the University of Regina's 2021 Research with Impact series. This series started in April and it's run monthly, and it's been, we think, really quite successful. There's been a lot of interest, so we appreciate that. I'm Dale Eisler. I'm a senior policy fellow here at the Johnson Sriama Graduate School of Public Policy at the University of Regina, and I'll be your host today. Over the next hour, we're going to hear from Dr. Tarun Katapally, who is a physician, a patient-oriented research leader, and a colleague of mine at JSGS, and a great friend. Before I officially introduce Tarun, I'd like to start by acknowledging that we are gathered virtually on Treaty 4 and Treaty 6 territories, the ancestral lands of the Cree, Saulteaux, Dakota, Lakota, and Nakota peoples, and the homeland of the Métis, on whose territories the University of Regina resides. So I'm here at the University of Regina. I live and work on Treaty 4 territory here at the University of Regina. The University of Regina's alumni department, together with the Lifelong Learning Center, is pleased to offer the Research with Impact series virtually, which is very much the reality of today's world, of course. And I've just learned that we'll be offering 3 more lectures with prominent researchers this fall. Further details on the upcoming lectures will be posted on the alumni website soon. And I think that will be visible in the chat section here shortly. I'm excited to hear from Tarun, and I hope that your time with us inspires you to come back for future sessions this fall. And I think I might add that Tarun's the discussion he's going to lead today is particularly relevant. I mean, given what we've been through over the last 18 months in terms of the pandemic. So I think it's a subject that's really crucially important. I also want to point out that these sessions are being recorded and will be posted on the U of R alumni website so that you can watch the presentations again or share them with others. You'll see the link to the alumni website in the chat if you'd like to access the video later. And now, it's my great pleasure to introduce our 5th speaker in this series, Dr. Tarun Katapally. Thank you for joining us. Tarun is an associate professor at the University of Johnson Sriama Graduate School of Public Policy. He established the Digital Epidemiology and Population Health Laboratory in 2017 to conceptualize virtual care and precision medicine applications. Tarun specializes in linking advanced mixed methods and complex analytical techniques with community-based participatory research. The objective is to understand the impact of policy and policy-driven contexts and systems on health and well-being of populations. Earlier this year, he was awarded more than $500,000 by the Canadian Institutes of Health Research to develop a long-term digital health solution for Indigenous communities. Today, Dr. Katapally will talk about the importance of equity when it comes to digital health. More importantly, he will address how digital health can potentially promote equity. Tarun will explore the concepts of citizen science in public health, social innovation for health promotion, and data sovereignty in the age of digital health. Following his presentation, we have about 15 minutes for a question and answer session. Hertha from the Lifelong Learning Center will be moderating the Q&A. As you listen to Dr. Katapally's presentation, please put your questions in the chat feature, which you'll find at the bottom of your screen. Hertha will share them with Tarun shortly after his presentation ends, and we'll do our best to get to as many questions as time allows. And now I will turn the floor over to Dr. Katapally. Tarun?
Thank you so much, Dale, and thanks everyone for joining today. I'd like to start off by saying that I'm grateful for this opportunity to share some of the work that we're doing. And, when it comes to research with impact, I always say that I struggle to balance my scientist side with my advocacy side. That's what I try to do all the time. Now, I'd like to share my screen. I'm not able to do that yet. If someone could give me the presenter view, I'll share my screen and start the presentation. Hertha or Sarah, if you have the time, please do that. Here we go. Can everyone see my screen?
Yes.
All right. Perfect. Okay. So, like I said, when I think about research with impact, I'm always thinking about balancing my scientist side with my advocacy side. And today, I want to talk about the future of public health and explore the concepts of citizen science and social innovation. Before I do that, I'd like to situate my own space in this area, how I've come to do this work. I started my career as a physician. If someone had told me, 10, 15 years ago, I'd be a professor, I'd probably laugh. I started my career as a physician, never thought I'd be a professor, but I got a PhD in epidemiology, and that led me down this path. A few years ago, I was awarded the Patient-Oriented Research Leader Award by the Saskatchewan Center for Patient-Oriented Research. So a lot of my work is informed by what I've done in the past. And if there's one aspect of me, I think that highlights the work that I do, it's that I'm an applied population health researcher. What I mean by applied population health researcher is I particularly do science, not just for the sake of science, but for applying it where it's needed the most. And that's the equity piece that I'd like to explore today, what equity means to me and how I apply my science in communities that need the science the most. So that's the professional side, but I identify myself as a settler scientist, and I'm incredibly fortunate that I'm able to develop population health solutions with our Indigenous partners, and I learn so much from them on a day-to-day basis. And I wouldn't be able to do that if I weren't a team builder. And it really does come down to building effective teams and working across teams. And that's how our research program is set up to work not only within academia, not only interdisciplinary research, but also intersectoral research with our partners in government, community, and across industry. So when I'm talking about all this work, the key word is populations, right? The focus is always on populations. It's not on the individual, it's on the populations. And that's where the equity piece comes into play. This is an image I use often to distinguish between equity and equality. Equity, particularly from a health perspective, to me means a fair and just opportunity for everyone to lead as healthy a lifestyle as possible. So I don't want to confuse by saying lifestyle. I don't mean to take this in an individualistic perspective, but it's if you think about healthy lifestyles, to me, what enables healthy lifestyles is equity. And when I think about equity, it's equitable resource distribution, and most importantly, equitable access to healthcare services, access to health services. So all the work that we do is informed by this lens of equity, and where we apply our science is informed by this lens of equity. Now, that's about the equity piece, but we have been in a digital age for a while. I'd love to say that we are entering a digital age, or we are in a digital age, but we have been in the digital age for a while. And there are different sources to this information, but because the big data we generate on a daily basis changes so much, the recent sources indicate that on a daily basis, we generate on average 1.7 MB of data per second. That's a lot of data. And when I think about digital health, and I'd like to say that I'm not funded by a smartphone company or a telecom company or big tech, but one thing that is apparent to me is access. And what does everyone have these days? Almost everyone, almost 95% of the Canadian population. It's access to smartphones. And that's the lens we take in providing equitable access. I think there are close to 3.5 billion smartphone users in the world. It's going to go up to 6 billion pretty soon in the next few years. So what does that mean? It's not just about the amount of big data that we can use in modeling our disease patterns, but also the ability to intervene in near real time and provide virtual care, healthcare services in near real time, potentially predict risk of communicable and non-communicable diseases in near real time. Now, that is the future. That's where we are headed. And I don't know how many of you have had the opportunity to do virtual physician appointments during the last 1.5 years, but that's just the start. I don't think we're going to go back to pre-pandemic days when it comes to those kind of virtual care services. What I'm talking about is even predicting the risk in real time before someone experiences any poor health outcomes. So that's where we are headed. And the idea of using smartphones to provide those sorts of services at the same time, use the data that ethically can be leveraged from our citizens and users. The key word is ethical. Ethically can be leveraged is the future of healthcare. And I don't want to scare anyone, but if you look at where big tech is investing these days, it's investing in health and healthcare. And if health systems want to have a seat at this table, they better start investing now. Otherwise, we might be looking at some health without health systems in the future. So that's the work that we are doing at the moment. But we can't ignore the current reality. And the current reality is that we have been in a pandemic for a while. And all we can think about is pandemics and future pandemics. But sometimes we forget that the existing epidemics and endemics haven't gone away. So in my worldview, this is what I see, that there is an overlap between pandemics, epidemics, and endemics. And I wouldn't want to go into the definitions of these things, but it's not just about communicable diseases when you think about pandemics, epidemics, and endemics. It's also non-communicable diseases. Think about the physical inactivity that has increased during this pandemic. And some people might think that there are different arguments whether physical inactivity is an epidemic or a pandemic. When you think about things like malaria, that you can think they're endemic to certain regions. I'm just giving these examples because these issues haven't gone away. And I don't know how to define where to place mental health or poor mental health, whether it's an epidemic or an endemic. That hasn't gone away. So that is the current reality. And what I think about is, could we have seen this coming? Could we have seen this pandemic coming? Yeah, the obvious answer is yes, we could have seen this coming. Unfortunately, for the first 1 year, our response was what it was in 1918, mask up, social distance. The vaccines have enabled us to get back to some sort of normalcy. Thank God for that. But for the first year or so, we just did what people did 100 years ago. So when I think about our research program, our research with impact, I'm always thinking, what can we do different next time? What is it that can be done differently? I mean, do we lock down really hard, like some countries like Australia and New Zealand? Do we invest in big data tracking and triaging like Israel, Taiwan, and South Korea? Or do we, invest primarily in vaccine? That's what we've done, develop boosters for vaccines and, variants. Or all of these approaches by themselves, to me, are quite reactionary. What is it that we can do proactively, especially because we have a history of short-term memories, and there's already discussion about the roaring 20s again. That's what happened the last time there was a pandemic, the influenza pandemic, around 1918. And I also think about what is missing from our approach. These are the questions that I think about on a daily basis. And I'm sorry if I'm raising more questions and providing answers here, but these are important questions that we have to ask ourselves. Perhaps even more importantly, what can we learn? I think some of the things that we've learned is the need for systems integration. It's not just about health, but also social services, justice, and education when you're responding to pandemics. I know this sounds like a basic thing. Probably the toughest thing to do is data share and link data effectively to come up with some real-time solutions. That is not easy in our siloed healthcare system, especially in Canada. It is really, really tough. And basic coordination of activities within jurisdictions and across jurisdictions. And there might be decision makers here who are listening to this. Even basic coordination of activities hasn't been easy. And how can we coordinate across different jurisdictions? I'm not even talking about provincial jurisdictions, but municipal jurisdictions. And why do we want to do all of this? I think it is not just for another pandemic or or a syndemic, but also for existing epidemics and endemics. And our focus, I think, the reason we need to do this is to respond more rapidly if we are to face the situation in the future. So, having laid that background, this is the reality. How do we go about doing this? And that's where I think the future of public health is. So, when we established this lab, the Digital Epidemiology and Population Health Lab, our focus was, let's not just do science. Let's not just do interdisciplinary science, but also collaborate with partners outside of academia to come up with solutions that we can actually implement. And when it comes to digital health, this means digital health products that can be launched in communities that are most in need and then scale them up. So that's just one of the examples. So the idea was always not just do science, but do science that has an impact across communities. The way we do this is using the SMART platform. I conceptualized the SMART platform many years ago. A lot of people ask me, is this a digital platform? Is it a virtual platform? I say it is a conceptual platform where we combine three key things. We combine ethical surveillance. Again, the key word is ethical surveillance. That means when we get data, our citizens and patients ethically provide that data and we make sure that they own the data. They can delete the data anytime they want. The next thing is we implement integrated knowledge translation. That means any work that we are doing, we try to translate that knowledge as we are doing that work, not at the end of a certain project. And perhaps most importantly, real-time interventions. Real-time interventions that will reduce the risk of communicable and non-communicable diseases. So we use this platform to develop multiple digital platforms or virtual care platforms. And that's something that I'd like to talk about a little bit today without going into too much detail. So at the beginning of the talk, I said we'll explore citizen science and social innovation. So the way we use SMART platform is by integrating citizen science and social innovation. Citizen science came from ecological sciences, where activists who would monitor data such as bird migration patterns or caribou migration patterns would put up the data in open source portals. What we have done is we've taken that concept and we've implemented it from a public health perspective. Now, it doesn't mean that citizen science for us doesn't mean that people are just collecting data and putting them up in open source platforms. It means that the research questions or the issues that we need to address can come from us as researchers or from communities or citizens themselves. So we collaborate to come up with some research questions or issues that we need to address. So for example, if we want to address the issue of youth suicide in remote communities, and that's because of that's a high priority issue. How do we use citizen science to address it? How do we develop our solutions? So what citizen science means is we not only collaborate, or citizens not only contribute and collaborate, but they also co-create. So that sharing of power is very important, especially when you're working with someone's data. So from a citizen science perspective, if we have patients or citizens working with us in developing say, a really cool digital tool, they own the data that they provide. That means that's where the data sovereignty comes into play. And I must say that of working with thousands of citizen scientists in Saskatchewan, we've had like one request for data deletion. And that is testament to the fact that we engage with our citizens equitably. That's where the equity piece comes into play. And we co-create our digital tools. We co-create our products. So that's the concept of citizen science that I believe in. Social innovation, there are many definitions to this. It's a process of developing and deploying effective solutions to challenging and often systemic social and environmental issues in support of social progress. That's pretty broad, and it might seem ambiguous. But to me, the social innovation piece is so interesting when we distill it down to working with, say, one jurisdiction or one community. What we've tried to do and what we've done effectively so far is, if we are going to develop a digital tool or a platform, we do it in close collaboration with one particular jurisdiction where they're able to use that digital tool to address some of the issues within their community. And that's where the social innovation piece comes into play. And that's where equitable sharing of, whether you call it data or power or information, comes into play. So there's this interesting interplay of social innovation and citizen science that we are using effectively in public health. And this idea is especially interesting when we're working with our Indigenous partners, where the issue, where the key issue is self-determination and self-governance. So think about using digital tools or platforms for self-determination and self-governance and data sovereignty. And that is transformative for us. And the ability to do that is what really excites our research group. So a good example of citizen science, social innovation, of the work that we're doing is a platform that we've been working on called Insync. This is a digital platform that we are developing in close collaboration with our Indigenous partners. I'll talk about them in a minute, to predict the risk of anxiety and depression among youth in remote communities. Now, the cool part about this for me, the part that excites me, is that the youth themselves are working with us in building this. We have a Youth Citizen Scientist Advisory Council, and we work with them closely to build this really cutting edge tool. And they didn't want to see the words anxiety or depression on the platform. They wanted a happiness advisor. So that's what we call it. And the way we engage with them in real time, we are able to get big data and use artificial intelligence to predict the risk of anxiety and depression. But for the user, for the youth, it seems like a tool that's a personalized precision medicine tool that provides them the right information to manage stress and anxiety or depression. And what we're doing is we're working with a team of data scientists, epidemiologists, Indigenous health researchers, our youth citizen scientists, to create a gamified, animated, and user-friendly interface for everyone to enjoy. And it actually enables them to connect with their own community too. So it is a very complex platform, but our approach has been to develop human-centered artificial intelligence. It's not artificial intelligence that is just using big data to come up with algorithms, but the human input is coming from our Indigenous youth citizen scientists themselves. That's one example of how we are doing this work. Now, while we were doing this work, of course, we were hit by the COVID-19 pandemic, and I actually came up with a global digital citizen science policy to tackle pandemics like COVID-19. And I was talking about this with our funders for a while. How can we use digital platforms not just for non-communicable diseases but also for communicable diseases? So I guess the timing was right. So I published this work, and that led to us working on a platform called Coway. Now, it's interesting how Coway came to being. What we wanted to do with Coway was develop a digital platform that would predict the risk of communicable diseases such as COVID-19 and provide the right information, the right time to the users so that they're able to take better decisions. So that's what we call a personal public health advisor. And we're not developing this just for COVID-19, but also for future communicable diseases, whether it's flu or HIV. We want to make it as broad and as sophisticated as possible. Again, we are working with the same indigenous community with whom we're working with for Insync, our mental health platform, to develop this. And we have a citizen scientist advisory council for this as well. So what came out from that human-centered AI or that engagement with our partners was that they don't just need a public health, like a personalized public health advisory tool, but also a tool that could help them report and address food security, and also a tool that could help them report issues with accessing healthcare services. And that's why we created two options. One was their citizen reporter option, where they could report issues with access to healthcare services, and another one for food security, where they could report the need for food. So now we are implementing this in one jurisdiction, where that jurisdiction is able to provide these services in near real time and own the data that's coming out of the platform. So all the data from this tool goes into a decision-making dashboard, anonymously, of course, and the mayor of the community is able to respond in real time. So that is what we feel is the kind of work that we do that addresses inequity, and that has an impact in communities that are most in need for a tool such as this. So that's the core of the work that we're doing. Now, the community that we're working with is called Isle of Lacrosse, and they are our phenomenal partners. It's a northern community. The latitude is 55 degrees north, and that's actually a picture I took there when I went there earlier this year. It was May, but there was still snow on the ground on the day I went there. Now, the reason I'm talking about this is the aerial view of Isle of Lacrosse, is this is cutting edge technology, but we are implementing this in Isle of Lacrosse. And it's quite easy to say that, hey, if you could do this in Isle of Lacrosse, you could do this everywhere. Yeah, but you know what? Not everyone has a vision that the community leaders in Isle of Lacrosse have. Yes, technically it's feasible to do that, but there needs to be political will. There needs to be participation from multiple organizations within a community. So the technology is there. Yes, this technology is scalable, but is there a will from the decision makers? And that's the kind of work that really excites us at the Depth Lab. So I just wanted to kind of make a point about that. So ultimately, it's the work is about systems change. And I might use some jargon here. What one of my mentors calls this, he calls the work that we're doing is inverting innovation. It's innovation, but we are completely inverting it. And what does that mean? Why are we inverting innovation? It's because we are decentralizing technology. When you think about big tech, you're thinking about companies in California who own all our data. But when you decentralize technology, it's the communities that own the data, the jurisdictions that own the data. And in particular with indigenous communities, that facilitates self-governance and self-determination with data sovereignty. So that is so important for us. but also we are democratizing policy because the citizens themselves are ethically participating in these platforms, so they have a say in how policy might be developed at a local jurisdictional level. So that to me, from a philosophical perspective, is the most exciting part of all the work that we do. I'd like to end. I wanted to keep this short. I wanted to end by saying that it really comes down to building teams, and I've been very lucky to build interdisciplinary, intersectoral, cross-Canadian, international teams to do this work. And it's not just the researchers that were helping us develop these products, but also our citizen scientists, and particularly our Indigenous communities, especially our partners in Isle La Crosse. And I'd like to thank them today for all the work that we do together. So I'll wrap up here. Like I said, I wanted to keep it really short, and I'll wrap up by saying one thing. 2 years ago, when I was talking about this work, I didn't have that big of an audience, but the pandemic has changed everything, and people have realized that digital health is here to stay. And I think that's why we've been funded again earlier this year, and I see our work really magnifying in the next few years. And this, to me, is the future of public health. Thank you.
Thank you very much, Tarun. That was really fascinating and incredibly relevant, given the state of the world these days and the health challenges that we face. Anyways, I'm sure there's going to be a lot of questions now. Hertha, I think we're gathering questions that were being put into the chat, I hope. Is that correct? You have them queued up?
I have no questions at all in the chat.
No questions in the chat. Okay, well then, I guess we'll just open it up to folks, whoever wants to speak up. If you just maybe turn on your camera and your microphone, and we'll recognize people as they kind of appear on our screen. Does anybody want to start things off?
Actually got two questions.
Okay.
Rewards and challenges of partnerships from Heather McDonald.
Okay. Tarun, do you see that?
I do see that. I think I made the rewards quite apparent. And I think the challenges of partnerships, I suppose it's bringing together everyone on the same page. If you're talking about health and healthcare, the work that we're doing needs support of not just our communities or industry or academia, but also the healthcare system itself. And bringing all partners on the same page, as anyone would know who has done work in this area, is quite challenging. And to do that in a timely fashion is sometimes frustrating. So because I feel like the ideas that come out of our lab are, we were talking about this 3 years ago. We were talking about potentially predicting the risk of anxiety and depression. And I might say very, very cautiously, because we are still working on this, potentially predicting the risk of even suicide in real time. We have to develop our algorithms. It might take a year or two for us to do that, and more than that. But to be honest, I wish we had the support 3 years ago, 4 years ago to do this. And now we are seeing some support, but that could be the challenge sometimes. Yeah, I hope that answers the question.
Okay. I got another one from Neil. Do you have any examples of any differences that your research has made on the street?
Yeah, I think we have many examples of that, on the street, in the actual impact of it. Now, the impact has been beyond Saskatchewan. We had 12 countries wanting to participate in this platform. This is on the street in addressing physical inactivity during the COVID-19 pandemic. And we have been able to engage with citizens outside of Canada in near real time to address their barriers and facilitators. I'm talking about physical inactivity here because we've had an international impact there. So that's one example of it. But if I think about, if I actually think about the virtual care aspect of it, we've had an impact where we have developed a platform that is now, pretty close. It's been tested pretty close to providing a service where people or citizens or patients are able to assess their risk of COVID-19 in real time. So yes, there've been some very gratifying results.
Okay, I got another one from Bonnie Mans. Is there any mistrust from anyone regarding putting information data on this system? What types of security measures are used in order to deal with this?
Yeah, I think that's a really, that's a question that gets asked quite often, and that's where the concept of citizen science plays a really big role in allaying fears or mistrust, because the partnership with our citizens and patients is equitable. So we have had very little or hardly any issues when it comes to mistrust, because when we are open about data sovereignty, when we are open about saying that citizens or patients own their data, they can delete their data in these platforms, the mistrust level goes down. So that's at the very get-go. When it comes to security measures, that's the thing that keeps me up the most. What we've done now is because of advances in machine learning, we are working with what we call federated machine learning models, where personally identifiable data doesn't leave people's devices. And any data that leaves people's devices is encrypted and anonymized. So even if the data are hacked, it should not be traced back to the individuals. That is of vital importance for us. And if anyone's been keeping tabs with data security, we are not going back to a non-digital age, but so many systems can be hacked, whether it's banking, whether it's healthcare, whether it's academic university systems. I think it was last year or the year before, University of Calgary had to pay ransomware. So that is the reality of our world. So how do we avoid that? How do we ensure that these data are not, do not identify our vulnerable individuals? That's the very core of our work, and we try to make sure that none of these data are personally identifiable.
Okay, I got another one from Devin. With the growth of digital data, excuse me, and the data analytics providing growth opportunity to private organizations, will the SMART platform remain an academic tool, or is there potential to take it to market?
The short answer is yes, there is potential to take it to the market. And I think that's already happening. The entrepreneurial side of it is happening, but we have to be very careful in how we do this. I think it's, there are so many other platforms that are coming out of smart platform, and it's one size doesn't fit all. So we are very careful in how we do this. Say, for example, if we're working with one jurisdiction and there's this idea that came from me or my lab, when it comes to data sovereignty, that jurisdiction owns the data. But when it comes to IP, we own the IP, unless something has been co-developed. And if it's been co-developed, there is IP sharing. So these are the issues that we do address when we think about scalability and potentially commercializing some of these tools.
Okay. From Mike, expecting people at large to be the root elements of the system, has that not been proved unreliable by the reaction of a large part of the population of COVID-19?
Well, I'd like to think that the human aspect makes our systems and our platforms better, not worse. There's always going to be challenges in how people react to these situations. And I think, what's worked for us is ensuring equal power sharing when we develop these platforms, data sharing, and to provide a value service. And I think that's the key. Any tool that we've developed, I think the success of that tool depends on it providing an actual value to our citizens or patients. And I've downloaded the Health Canada app. It's for COVID-19, and as the intent is right, but it really doesn't provide me the necessary information, or it doesn't facilitate me to behave in a way that would help me mitigate my risk of COVID-19. And what we have done with Coway is potentially develop a precision medicine tool that will help people make better decisions. It's their own personal health advisor. So that, to a large extent, that approach has mitigated some of the issues that we would normally face.
And I don't have any more questions on the chat.
Maybe if I could just follow up on Mike's question, and I don't know if it follows necessarily, and I don't know if it's really relevant for your work, Tarun, but because this isn't public opinion research you're engaged in, something completely different. But because people opt in to this, right? Are there issues, in health terms, science terms, are there questions then around a representative sample? Is it, a suitable cross-section that you can actually draw reliable conclusions from?
Great question, Dale. I think the way we've addressed representation is incredibly involve the whole population in the process. So, for example, when we worked with high schools in Regina, we pretty much included every youth in a project. So there was no issue of representation. And the same approach is being taken when we work with communities in the north, such as Isle of Cross, is include most of the population. So the issue of representation just goes out the window when you've got pretty much the entire population participating. Now, the challenge is going to be when you scale these products up, right? So that's where, if we scale these products up, whether we do it in partnership with the provinces or territories, or whether we commercialize them, then we go into the realm of business, and that's what's going to happen, right? So yes, these are research based, but anyone in the world can use a personal public health advisor. So the representation can be varied from jurisdiction to jurisdiction. Our hope is to potentially provide services to anyone who wants to use these tools, but it depends on the goal of the project. If the goal of the project is research, then we make sure that we address representativeness right off the bat. We make sure that we include most of the population in our sample. But if it's purely a commercial tool, I'm talking 2 to 3 years from now, then we might not have as good a representation as you might expect due to various reasons, digital illiteracy, internet inequity, so many things. So it's going to be fascinating how this field expands.
Other questions from folks? Maybe while people are thinking about a question, I'm wondering, Tarun, I mean, we're living in an age, I guess we would say, unfortunately, kind of an anti-science age in a sense, in terms of, public response and at least a significant segment of the population. I'm wondering, where people just sort of reject facts, don't accept them, or, have their own set of facts, they think. Is that, have you found that to be an impediment or barrier in your work at all?
I mean, really great question, right? Because some of the work that we're doing is not just for the sake of science or health, but also it provides us an opportunity to address misinformation, right, through these tools. The approach that we have taken is to engage our citizens or patients from the get-go, so that they participate in the development process, and that builds some confidence. I mean, I'll give you an example that there's a lot of vaccine hesitancy in the north, in Saskatchewan, and I've experienced that when I've engaged with people, perfectly nice people, but there's a lot of vaccine hesitancy, not necessarily because of distrust in science, but distrust in colonial systems per se, right? There could be, and there could be all sorts of intersections. The way that we worked around that so far is to ensure that we embed our platforms into local decision-making processes. What I mean by that is, I'll give you an example of this Health Canada app, why it has failed. I think an app like that would work better if it's driven through, for example, if I have a primary care physician or a GP in UK, and they are participating in these applications, and the information that I'm providing is going to them, I have more faith in the system. This is not done by big tech or someone in Ottawa. So we're trying to decentralize the technology to a local jurisdictional level so that that mistrust is minimized if possible. It's not always going to work out the way we want it to work out, and I'm happy to extrapolate this in a completely different area, extrapolate this and talk about what's happening right now with vaccine mandates. Now, a lot of people, there might be 20% of the people who will say, I will not take a vaccine at any cost. But if travel industry is going to mandate vaccines, if you want to travel, you have to take a vaccination. This is going to be an interesting thing as we move forward, right? And I'm not saying that, hey, digital health is the way to go. If you don't participate, you'll be left out. But honestly, if you don't have access to internet, if you don't have access to smartphones, internet is deemed by the UN as a human right now. So what I'm trying to say in a long-winded way is I hope everyone eventually realizes the value these tools provide.
I think we have another question, Hertha, from Carrie.
Yeah, it's a comment. I think I'm reading it. Absolutely. I think the systemic issue is lack of access or poor access to internet. And it's such a disparate thing that a community like Isle La Crosse that I just mentioned has better internet service than some indigenous communities that I work with in southern Saskatchewan that might be 45 minutes away from Regina. So it's so disparate, right? And that is a systemic issue that we have to face. And most people, I'm not talking about, people in the high SES strata, most people get their access to internet through smartphones and through data plans. And if they are not able to afford good data plans, how can they participate in these platforms? How can they access virtual care services in the future? So that is the systemic issue. And I know the feds have come up with a plan in the last budget to provide equal or equitable internet access to all Canadians by 2030. Good, but I think it should happen by 2025. That's where we are headed. But this is the future of public health, not just public health. That is the future. We are in the digital age, and we all know how we worked for the last 16 months. I mean, without internet, I'd be completely handicapped.
Okay, anyone else want to weigh in? Just speak up if you do. Any questions or comments or observations? Oh, Greta, you look like you're going to say something. No? Okay. Okay, well, going once, twice, 3 times. All right. Well, listen, I want to thank everyone for joining us today, contributing to the conversation, and special thanks to Tarun for sharing your expertise and time with us on a subject that is critically important in terms of our health, public health, and society generally. And I mean, it is the new world we're moving into in terms of public health. So I agree entirely. I'll remind people that a video of today's Research with Impact lecture will be posted on the alumni section of our website, and a link to the website can be found in the chat. Feel free to share the link with your family and friends and anyone else. And don't forget to check out the U of R website for information on lectures in this series and more. As I mentioned previously, we're extending the U of R's Research with Impact series, and we'll be providing 3 more lectures with prominent university researchers in September, October, and November. So visit the alumni site for details on speakers and their topics. The next lecture is going to be on September 21st, same virtual place, same time, noon to 1 p.m. So people can join and eat their lunch and listen in and find out about new important research that's going on at the university. So I hope you can join us for the next one. And until then, enjoy the rest of the summer. It's fading away fast, and Labor Day is just around the corner, but hopefully people will stay safe and stay healthy, and hopefully we'll see you again at our next lecture. Thanks very much.